Welcome to the Deep Dive. We're here to take tricky, complex information and, well, make it make sense for you. Clear, useful, the key takeaways.
Basically, your shortcut to getting a solid grip on important topics.
Exactly. And today, it's a really tough subject, but incredibly important. Non-accidental injury, or NAI.
Yeah, often called child abuse. It's sensitive, no doubt, but understanding it is crucial. So that's our mission for this deep dive.
Right. We've got these revision notes, and the plan is to give you a really clear, high-yield overview. Hit the main points so they stick. So let's start right at the beginning. What exactly is non-accidental injury?
Okay, so at its heart, NAI is harm done to a child on purpose, intentionally. And it's usually by a caregiver, someone the child should be able to trust.
And it's not just physical hitting, right?
No, absolutely not. That's key. It covers physical abuse, yes, but also sexual abuse, emotional abuse, and importantly, neglect, failing to provide basic needs. It's basically a severe form of child maltreatment, a fundamental violation of that child's rights. Think of it as a deliberate action or sometimes a deliberate inaction that harms a child.
Got it. Deliberate harm or neglect. So what leads to something like this? What are the causes, the etiology?
Well, it's rarely straightforward. It's almost always multifactorial. There isn't just one single cause, usually.
Like a perfect storm sort of thing.
Kind of, yeah. Big factors include things like significant parental stress, maybe mental health problems in the caregiver, substance abuse is often involved. And sadly, if the perpetrator was abused themselves, that's a major factor too. Plus, things like social isolation, lack of support, and just really dysfunctional family dynamics can all contribute.
So a real combination of personal, social, and maybe environmental pressures piling up.
Exactly. That's a good way to put it.
Okay. That makes sense, unfortunately. So are there particular circumstances or factors that make it more likely? What are the specific risk factors we should know?
Yeah, so risk factors are things that increase the statistical likelihood of abuse happening. They don't guarantee it, of course, but the risk goes up.
Right, like warning signs.
Sort of. Things like young parental age or being in a single-parent household, sometimes low socioeconomic status, which often links back to higher stress and maybe fewer resources. Also, parental substance abuse, like we mentioned. Domestic violence in the home is a big one. A parent's own history of abuse. And again, that's social isolation, not having a support network.
So those factors create a higher risk environment.
Precisely. They indicate a higher chance of vulnerability.
Okay. Now, thinking about how this shows up physically, the pathophysiology, the notes we have here mention myopathies. That's muscle disease, isn't it? How does that fit with NAI?
Yes. This is actually a really crucial clarification point. That section on myopathies, muscle fiber damage, weakness, it does not directly relate to NAI itself.
Oh, okay. So it's separate.
Yes. It seems like it might have been part of broader revision material, but it's not part of the mechanism of non-accidental injury. So for NAI, we need to set that specific point aside.
Right. Good to clarify. So for getting to myopathies then, how does NAI actually manifest physically? What are the real signs we might see on a child?
The physical signs come directly from that intentional harm or neglect. So you might see direct trauma injuries. Bruises are common, but pay attention to where they are. Torso, ears, neck, buttocks. Places kids don't usually bruise accidentally. Or bruises that have a specific shape, like a handprint or maybe the shape of an object. Fractures are another major sign, especially in babies who aren't mobile yet.
Right, because how would they break a bone just lying there?
Exactly. Or seeing multiple fractures, maybe at different stages of healing, suggesting repeated injuries over time. Burns are another one, especially immersion burns, like dunking a hand or foot in hot water, which can leave a very sharp line, like a tide mark. And head injuries, of course. Then there's neglect. That might look like malnutrition, the child being dehydrated, poor hygiene, maybe lots of untreated infections or severe diaper rash.
So like a wide range of physical signs.
It is. And even emotional abuse, while not leaving visible marks initially, can sometimes impact physical development, like failure to thrive.
That's a lot to take in. So if a child comes in with some of these injuries, how do doctors or healthcare workers make sure they're not jumping to conclusions? What else could it be? The differential diagnoses.
That's absolutely vital. You have to consider other possibilities, the differential diagnosis. Could these signs be caused by something else?
Like what?
Well, The most common alternative is just normal accidental trauma. Kids fall, they bump into things. You have to assess if the injury matches the story of the accident.
Okay.
But then there are underlying medical conditions, things that can cause easy bruising, like hemophilia or other bleeding disorders, or conditions that make bones fragile, like osteogenesis imperfecta brittle bone disease. Even things like osteoporosis, though rarer in kids, could be a factor. So a really thorough evaluation is needed. Taking a detailed history, maybe doing specific blood tests or genetic tests to rule these things out before concluding it's NAI.
It's like being a detective weighing all the evidence.
It really is. You have to exclude other causes carefully.
So how common is this? What's the epidemiology? Do we know how many children are affected?
That's difficult to pin down exactly. There's a lot of underreporting, as you can imagine. Families might hide it, kids might be too scared or too young to say anything.
Sure.
But we absolutely know it's a major public health problem. Thousands and thousands of cases are confirmed each year, and that's likely just the tip of the iceberg.
And certain kids are more vulnerable.
Yes. Infants and very young children are definitely the most vulnerable. They're completely dependent, and we do tend to see higher reported rates in situations with more socioeconomic stress, which, again, probably links to those risk factors we talked about: stress, lack of support. It's a serious, widespread issue.
Okay. And what are the specific things, maybe the patterns or combinations of signs, that would make someone strongly suspect NAI when they encounter a child? The clinical presentation.
Right, the clinical features. We can kind of group them into physical signs and then emotional or behavioral signs.
Okay. Physical first.
Physically, it's often about unexplained injuries or injuries that just don't quite fit the explanation given. Those bruises in weird places or patterned bruises, fractures that seem too severe for the story or fractures in babies, burns with clear lines. Also, a delay in seeking medical help for a significant injury can be a flag.
And the emotional or behavioral side.
That can be varied.
Yeah.
You might see a child who is excessively fearful, especially around their caregivers. They might be very withdrawn, anxious, maybe overly compliant or watchful. Or the opposite, unusual aggression, maybe sudden changes in behavior like regressing to earlier behaviors. Developmental delays can sometimes be linked too, and often a reluctance or inability to explain how the injury happened.
So if these signs are present, what are the absolute key things, the big red flags that scream, consider NAI?
Okay, there are some really strong indicators. Number one is probably an inconsistent history. The caregiver story about how the injury happened changes, or it just doesn't logically explain the injury itself.
The story doesn't fit the facts.
Exactly. Second, injuries that are just not typical for the child's age or developmental stage. Think spiral fractures in an infant who can't walk yet. That's highly suspicious.
Right.
Third, sometimes you see evidence of poor parent-child bonding. Maybe the caregiver seems detached or overly critical. Fourth, if the child or family is already known to social services for concerns, that obviously raises the index of suspicion.
Is there a way to remember those key ones?
Some people use a mnemonic, maybe thinking of the eyes. Inconsistent history, injury doesn't fit the story or stage, infant injuries, especially fractures head trauma, impaired bonding, and already known to services. The 5 eyes.
Inconsistent, injury, infant, impaired, known. Okay, that's helpful. And presumably, the risk factors we discussed earlier add weight to these suspicions.
Oh, absolutely. If you see suspicious injuries and you know there's domestic violence or substance abuse or significant untreated mental health issues in the home, your level of concern has to increase.
But you still need to be careful not to jump to conclusions based only on risk factors.
Definitely. You gather all the information, approach it non-judgmentally at first, document everything meticulously, but those risk factors provide important context.
Okay. So suspicion is high. What happens next? What investigations are typically done to confirm or explore further?
It triggers a really comprehensive evaluation. It always starts with taking a very detailed history from caregivers, anyone else present, and the child, if they're old enough, asking open-ended questions. Then a thorough head-to-toe physical examination looking for any other signs.
And tests.
Imaging is crucial. X-rays are standard to look for fractures, not just the obvious one, but others too. A CT scan of the head might be needed if there's concern about head trauma. Blood tests, like a full blood count, clotting screen, are important to rule out those medical causes we talked about, like bleeding disorders. And critically, this process involves reporting to and collaborating with child protection services. They have a legal duty to investigate and ensure the child's safety.
Are there other, more specialized investigations sometimes?
Yes, definitely.
Hmm.
Especially in younger children, under 2 usually, a full skeletal survey is often recommended. That's x-rays of all the bones in the body to look for hidden or older fractures.
Wow, the whole skeleton.
Yep. And an ophthalmology review and eye exam by a specialist is really important, looking for retinal hemorrhages, which can be a specific sign of abusive head trauma, sometimes called shaken baby syndrome. And depending on the situation, maybe more specific blood tests or scans, you have to be thorough.
It sounds incredibly thorough, which is reassuring. So once NAI is strongly suspected or even confirmed, what's the plan? How is it managed? What happens to help the child and, well, the family?
Management is complex and always involves a multidisciplinary team. You've got the medical team treating injuries, child protection services assessing safety and coordinating care. Sometimes law enforcement gets involved, mental health
A
professionals.
whole network.
Absolutely. The number one non-negotiable priority is the child's immediate safety. If there's ongoing risk, that might mean removing the child from the home, at least temporarily.
Okay.
Then there's treatment for any physical injuries. But also, crucially, therapy and counseling for the child to help them process the trauma. Support might also be offered to the family, things like parenting skills programs, therapy for the caregivers, treatment for substance abuse or mental health issues, aiming to make the home safe if that's possible and appropriate.
It must be a very difficult balance sometimes regarding confidentiality versus needing to protect the child. How is that handled?
That's a huge ethical consideration for anyone working with children. The rule is clear. Child safety overrides confidentiality. If you suspect NAI, you have a duty to report it.
Even if the parent asks you not to.
Yes. You should always document your concerns thoroughly, discuss them with a senior colleague or your organization's safeguarding lead first. Ideally, you'd try to discuss your concerns openly with the family and explain why you need to share information with child protection services. Maybe seek their consent if it doesn't increase risk. But if you have reasonable ground to suspect a child is at risk, you must share that information with the appropriate authorities, consent or no consent. The child's welfare is paramount.
That's a heavy responsibility.
It is. And ongoing management is tailored to each specific case. Sometimes the focus is on improving parenting, sometimes long-term support is needed, sometimes, sadly, reunification isn't safe or possible. Removing a child is always a last resort, only done when their safety is immediately threatened.
What about the long term? For children who've been through this, what's the outlook, the prognosis, and potential complications?
It really varies a lot. It depends on things like how severe the abuse was, how long it went on, the child's age when it happened, and critically, how much support and effective intervention they received afterwards.
So getting help makes a difference.
A huge difference. Early identification, getting the child safe, providing therapy and support that significantly improves the chances of recovery and resilience.
But there can still be lasting effects.
Unfortunately, yes. NAI can have really profound and long-lasting consequences. Physically, there might be chronic pain or disability from injuries. Emotionally and psychologically, the impact can be huge. Anxiety, depression, PTSD, difficulty trusting people, problems with relationships later in life. Behavioral problems can persist. And tragically, experiencing abuse as a child increases the risk of becoming involved in violence later, either as a victim or sometimes a perpetrator. The impact can ripple right through into adulthood.
Wow, this has been, well, it's a heavy topic, but so important to understand clearly. It really underscores how serious NAI is and the deep lasting harm it can cause.
Absolutely. The key things to remember are those risk factors, the signs to look out for both physical and behavioral, and the absolute necessity of a careful, thorough, multi-agency approach when concerns arise.
Definitely. So maybe a final thought for everyone listening. Perhaps consider the broader picture. What are the societal factors, the stresses, the lack of support systems that might contribute to these situations? And what role can each of us play, even just being aware, in helping to safeguard children?
That's a powerful point. And if you are studying for exams or just want to learn more and solidify this knowledge, remember to check out passthemsra.com.
And there are free resources, too, at freemsra.com. Definitely worth exploring.